I'm going to talk about it. The program is a little bit misleading. It says talking about AI and MRI. I'm not going to do that. I'm going to talk about the ARDL, the Air Reconstruction Deep Learning package that you can now utilize on GE machinery. And I've called this lecture The Best of Both Worlds. And it's quite an ambitious title, because I'm trying to make the suggestion that this particular AI technique can make acquisition of your images faster and can improve the quality of the images that are produced. And it can be done at the same time. Now, anyone who's worked in MR understands these are rather bold assertions, rather over the top. If you've been in MR for some time, you'll have come across many manufacturers coming to you and saying, we can make this go faster. It'll give you more patience to do and improve your workflow. You'll get better resolution. We can do it all. We can reduce artifacts, etc., etc. And most of us have been profoundly disappointed by those assertions over the years. You know, they sound great, and when you come down to it, it's, you know, not quite that good, is it? So let's talk a little bit about how you actually go faster. What's the way to go faster and better? First of all, we have hardware solutions. Whoops, sorry. There we are. Trying to get used to this. So, hardware solutions, higher field strengths, better magnets, low noise receive chains, more radio frequency coil elements for more signal reception. All these have been introduced, and they do improve signal to noise. Don't necessarily make you go that much faster, but they do improve signal. Signal to noise, of course, is easily improved by all of us by increasing the number of signal averages. We all know that. The trouble is that has a very substantial time penalty in many instances. You know, if you do 4 or even more signal to noise ratio, excitations, you can improve what you get. However, it triples, quadruples, etc. your time. Then we go on to the other things like parallel imaging, partial Fourier components, such as compressed sensing. They can reconstruct images from subsample data. But remember, you're subsampling the data. And there's often a significant downside of spatial resolution and lower signal to noise. But they go quicker. So you have multiple different trade-offs that you would have to reconcile in your daily practice. If you're going to use those techniques, you may have to sacrifice image quality to get the faster scan time. And you will have to make that decision based on the individual patients and the clinical needs. If you have a claustrophobic patient, if you have a patient who's messing about and twiddling and annoying you in the scanner because they're moving and giving you rotten images, you have to be able to try and overcome that by speeding it up. But you will often sacrifice image quality in doing so, okay? Now, most of our current go faster techniques try and accelerate the acquisition of case space, usually by partial case space filling. I'm sure you're all familiar with that. The reality is that there's very little capacity remaining in the technology to get further significant, impactful acceleration of image acquisition using these partial case space filling techniques. ARDL is quite different. It's not that partial case space technique. It is a pipeline that takes the raw case space data as its input and generates high quality images as its output, which is a completely different perspective. That is to say, the ARDL AI technique works on the case space data that you've got before it's transformed. And here's a sort of a vague explanation. What it does is it produces higher signal to noise ratio, and you can control that against image time, improve resolution, and above all else, the ARDL technique reduces ringing and truncation artifacts. At the moment, we're using it on 2D, 2D system, 2D acquisitions, which produce the raw data here. But we will be soon, we hope very soon, be able to use it on propeller techniques and 3D techniques, as you can see down the bottom, to produce that case space data on which the AIR Recon will work to produce the better quality images. So, let's just talk a little bit more detail about how these types of things work. And the key phrase, if you want to look good when you're explaining to someone, is to call it a convolutional neural network. Okay? Key word, key phrase there, if you want to look impressive. And that operates on the raw, complex data that produces the output image. It cleans it up. It works by producing a tunable reduction in imaging noise. That is to say, you can swap imaging time for noise reduction and all these sorts of things. And you have the ability to move these things around on your console to decide what is best for your patient, your individual patient that you have in front of you. The biggest thing actually is the reduction of truncation artifacts, but you also improve edge sharpness, and above all else, the thing to remember is this is an AI technique. And for most of us in radiology, AI is pretty scary, particularly for us radiologists, because lots of AI developments seek to use it to report images, show you lumps and bumps that you otherwise, of course, are missing. You know, I wouldn't know that they're there until an AI tells me. And theoretically, they want to replace radiologists. Now, in many instances, I think this is unlikely to ever happen. I think some people are really going over the top in this end. But it's important to use AI, to be involved in it, so that we are its gatekeepers and controllers, not its victims. And we have to learn how to utilize AI rather than it utilizing us. Does that strike a chord with what I'm talking about? You know? Now, this is a horrible slide, but it has some points. And it talks about sort of way we're using AI. Now, ARDL is deep learning, which is supposedly the most advanced form of machine learning. Now, here is a slide that is using AI. And what we're trying to do in this slide is train a machine to separate cats from dogs. And it has all this stuff here, all this deep learning stuff, convolutional neural networks, and we teach it to separate cats from dogs. And by the end, it can separate a cat from a dog. But if you then go back and say, actually, I wanted to know how many white dogs there were, you can't do that, because you've only trained it to separate cats from dogs. Whoops. So what you have to keep in mind is that the training is only as good as the data input into it. And there is the real concept of garbage in, garbage out. It will only do what you train it to do. So let's talk a bit more about ARDL. It improves signal, spatial resolution, contrast, and lessens ringing artifacts, and improves image quality in our regular sequences. At the moment, we can't apply it to 3D volumes and propeller, that's motion suppression, but that's coming along, and it's available starting now. It does not work by altering individual pathologies, and does not influence the nature of the pathologies you see on MR imaging. It simply makes the images better. Now, when you present this to many of our radiological colleagues, they say, "Oh, AI technique, I'm not so sure. I don't like that idea at all." Because they are worried that it's going to start putting boxes around bits that they need to describe. Whereas in reality, this does not affect imaging pathologies. It is purely improving the quality of the images. And the interesting thing here is that you can also swap some of the quality for time aspects. So if you want to, for instance, keep the same quality of the imaging that you have now, when you put ARDL on, you can do that same study in half the time. Alternatively, you can improve the quality of your imaging and save a substantial amount of time still by getting it, by balancing both those factors together. So you can get time benefit and quality benefit. And remember, this version has only been trained to reduce MR artifacts, improve signal, improve edge appearance, and it does not carry on learning. When you've installed the system, it's not keeping on learning. It has already been trained and does not take anything further, unlike many other AI systems which carry on grabbing the imaging data and trying to do something else. And again, I specify there is no pathological specificity here at all. Now, given that this is an AI development and given this is 2023, I thought for a lark I would go on to ChatGPT and ask the AI bot to write me a lecture on ARDL. And here's the result. And it's disarmingly good. ChatGPT is having a massive influence in all sorts of academic areas. Most people these days who are at university and are asked to write a letter on an essay on something go straight onto this and do it. And there's huge problems about that. Anyway, here's what ChatGPT said, and it's pretty good. Now, let's start looking at some imaging data slowly to try and get you into the mood. This is what happens normally. The raw data filtered, this is case-based, raw data filtered, transformed into imaging. Still with lots of artifacts. Spatial resolution isn't all that wonderful, lots of truncation artifacts. Now, before we do some imaging, we traditionally do phantom work. So here are some phantoms. These are two phantoms done with the same factors, but this one over here has ARDL on it. This one does not. This one does not. And you can see immediately that there is a massive difference in the detail. There are lots of ring artifacts here, but when we put it up here, when we use ARDL, you can see how it's reducing the ring artifacts and giving you better detail. Now, we talked about Gibbs artifacts, truncation artifacts, and these are undersampling artifacts, traditionally, right? So here, with these phantoms, we have tried to undersample these phantoms by using low matrices and very short times to magnify Gibbs artifacts. And here you can see fairly sort of woolly image with ill-defined details. But if we apply ARDL to the same factors, we haven't changed the factors, we're still trying to undersample it, and it's hugely improved. And probably these bits are best to look at, compare these two. See how you improve that? And the final phantom is about spatial resolution. Here we've set quite a high matrix to try and visualize the details of these lines. And then we've repeated that with ARDL on the case. And look at the spatial resolution of these bits. Looks pretty poor here, doesn't it? With that high matrix. And here's the ARDL, and look how it improves. Massive improvement by getting rid of the truncation artifacts and improving the spatial resolution. If you want to graphically represent this for time and voxel volumes and things, this is the way you can do it. Here you have our ARDL image. Now that line there is the clinical threshold for getting a decent image. So with ARDL, we can produce a decent image just there. But if you want to use the same voxel volume with a conventional image, it's below that clinical threshold line. To get to the same level as that, you need to take the voxel volume way up there. So you need much more in your each voxel to produce the same level of detail, to produce an acceptable clinical image. Same goes for time. Here's our ARDL image above the clinical threshold. But if you want to use the same scan time, which is down here, you're below the level of acceptable imaging. And to get to that same level of signal to noise ratio, you have to take it all the way up here, which, as you can see, is a huge increase in time. Okay, enough of that. Let's show you some images. We've done all the basics now. We're all happy. We know what's happening. Does it work? Well, here are just a miscellany of images just to start off. You can see that in MSK, you can go from that to that, huge improvement. Livers, much improved. Cardiac work, look at the details of the myocardium. Look, fantastic. Brain, similar, very substantial improvements. Okay, so it works all over the body. This one is something I found very interesting, because I'm predominantly an abdominal imager. Here's a gradient echo sequence, and if you had asked me 9 months ago, what are these lines here, I would have confidently said breathing. Movement from breathing. What do I know? Same in the kidney. Look at the kidney. Look, all sorts of little lines there. It's clearly breathing artifact. Clearly it isn't. It's ringing artifact, truncation artifact. And when you apply ARDL to that same image, you get rid of all those lines at the front and around that kidney in a much better image. So truncation artifacts plays a huge role in the quality of your imaging. Is there much evidence to support that ARDL works? Well, there are about 23 publications in peer-reviewed journals from all over the world, all sorts of different areas of the body, showing you that it does. Lots of global installations, more than 10 million patients have been scanned. So it's not a new thing. It's not a fly-by-night piece of work. It is becoming well accepted. How is it changing our service? Very conservatively, and you'll hear much more about this later on from David, but we reckon conservatively we can produce a 15% reduction of scan time for our routine neuro appointments, increase at least 2 outpatient slots a day. That's probably an underestimate. You can go further. We've established a pathway for claustrophobic patients. Lots of new guidelines that are coming in that would otherwise prolong our scanning. We can bring back into a reasonable time frame. We can increase our patient capacity. And here's the interesting thing, and I'll talk about this more later on. We've unlocked the potential on our older machines to improve the quality of the imaging. And we'll talk about that. Improve radiographer experience. I think that's overrated, isn't it? Okay. Routine head. And you can see down the bottom, 17 minutes with these sounds. If you put ARDL on it, immediately takes it down to 13 minutes. So that's a big improvement. And here's the sort of quality you can expect. This is a conventional one. Yeah, that's our conventional one with a scan time of 2 minutes. Here, we've taken the pixel matrix way up, much better quality scan at the same time. So look from one to the other, and if you look carefully, there is a substantial improvement in quality on this second one. Same time. Better quality images, same time. Here, we've got a scan time of 4 minutes, and we've kept the same pixel size, but we've done it in more than a minute less. And the quality I think, is significantly better in this one than here, despite and whilst keeping the same matrix size, okay? This is our old Explorer. Now, for the rest of this study, I'm going to start dotting between machines, and I need to introduce that to you. Explorers are our 12-year-old 1.5T machines, which were aging quite badly. And the Artist, which I'll show you some images, is our brand new 1.5T, which is the top of the range 1.5 at the moment. Now, here is a cervical spine done on the Explorer. Same patient, by the way, same patient, done a year and a half, 2 years ago. And you can see quality is ho-hum. Scan time, 4 minutes. This one, now, same patient, scan time, 2 minutes 20. Much improved. Yeah, I think that's very convincing. Let's talk about the claustrophobic patient pathway. Lumbar spines. Conventional lumbar spine, 15 minutes. With ARDL, we can take that straight down to 8 minutes. Almost half. But if you have a particularly mobile, annoying claustrophobic patient, you can take it down to 6 minutes. And here are some of the image quality from that fast scanning time. Look, 2 minutes, 1 minute 20 for good quality images. Same for more from that same sequence, a minute for that T-spine. So good quality images done very fast. Here's the new cauda-equina syndrome protocol. Now, the recommendations are that if you have a patient with suspected cauda-equina problems and you don't see anything on the lumbar spine, you have to do a T2 image of the whole spine. That adds a bit of time to you, doesn't it? Here we are. Conventional, 18 minutes and 40 seconds. You put ARDL on, 9 minutes. So you've halved the scan time. If you really want to push it, you can go to 7 minutes 40 for a claustrophobic patient. And here are some images from that very fast claustrophobic protocol, which to my eye look extremely acceptable and effective for diagnosis. Now, let's talk a bit more about the new scanner we've got, the Artist, and the 12-year-old scanner. Here are some images done last year on the Artist. Brand new machine, 4 minutes 30 for that. Good quality images. Yeah? Same patient, done on the Explorer after it's been turned up to ARDL, and I would say it's better. Scan time, 2 minutes. One excitation with images that are a bit better. That's rather remarkable, isn't it? Brand new machine, rubbish old 12-year machine, look what you can do. Same patient, same setup. The previous image from the Artist, current image from the Explorer, 12-year-old machine with ARDL, quicker time, 3 minutes 30, and images quality better. Same again, coronal, just in case you're not convinced. We've taken a minute off the time from the Artist and we've produced better images. Here are some patients before and after on just the old machine, the Explorer, the 1.5T, which, as I said, was fading badly. This is before ARDL was put on. Not a bad image, but here, same time, but a hugely improved image. Look, you can see all the details of this patient with endometriosis. The previous one also had endometriosis. All sorts of fibrous bands all over the place, clearly defined where you can see them. And what we have done here is we have improved a 12-year-old scanner, and allowed it to really produce very good images, which is quite a remarkable thing. Here again, same sort of format. This is a fibroid patient in the pelvis 2 years ago. Currently, again, much quicker, this one, and improved quality. Musculoskeletal work. Does it work there too? Yes, it does. Simple T2 fat sat knee, 4 minutes, moving on to 3.5 minutes, greatly improved image. Faster image, better quality. Same patient, 3 years apart, 4 minutes, 2 minutes. Better quality at 2 minutes than the one at 4 minutes, all on the old machines. T1 for the same effect, quicker and better. And again, same effect here, just to make sure you get the point. Faster and better. I'm a bit boring, I know, I'm repeating myself, I'm sorry. Shoulder. Same again. Before ARDL, after ARDL, quicker and better. There it is again. I don't do AMSK, so I'm going to go through this quite quickly because it's just MSK stuff. But again, quality can be improved, and these are all ARDL, but look at the quality in 2 minutes, 3 minutes, really quick. So, just to reinforce that, we have two 12-year-old 1.5T Signa GE Explorers. They've been upgraded and all that sort of stuff, but it really didn't make a huge difference to the image quality and the speed until we had ARDL installed on them. And that has allowed us to produce a huge improvement in image quality and a concurrent speed improvement. And now the Explorer images are as good as the new, perhaps slightly better, Artist, prior to that also being upgraded to ARDL, and at a fraction of the upgrade cost or a new magnet cost. So what I'm trying to say here is instead of frantically looking for some way to replace these old machines, they now have a further useful lease of life, producing high-quality diagnostic imaging with some time benefit as well. Our machines are buried deep in the basement. When I asked one of the GE engineers a few years ago how we could move those machines up to the department here, which is on that third floor just over there, what would be the cheapest way to move those machines? He said, well, what you need to do is put a big pipe through the window of that downstairs basement, then fill the whole area with concrete and buy new machines. So they're deeply embedded. We're never going to do anything with them in this old hospital. But we've actually been incredibly impressed by installing ARDL on. It has allowed us to keep those machines going. I no longer moan continuously about the quality, which I suppose is one of the ways. We were talking about improving the experience of the radiographers earlier on, and I suppose that's how it works. I don't have to moan at them quite so much. Here's a horrible cartoon. It's very American, this cartoon. We've got over here, we've got Mr. Equivocal, who can't make his mind up, and when he's installed ARDL, he's Mr. Certain. Pathetic, I know, but it makes a point. So, conclusions. For MR service delivery, ARDL has the potential to increase your capacity. You can use it on all your routine cases to either improve quality, reduce scan time, or find a happy balance of both those, which most people do. Improve your claustrophobic pathways, improve patient outcomes by improved resolution, and prolong the life or rejuvenate aging machinery with substantial potential cost savings. So in conclusion, I hope that I've proven those two things I said at the beginning, that it is possibly the best of both worlds by improving the quality and shortening the scan times with the introduction of this type of AI technology. And I'm going to stop there. Thank you very much.